Good morning. I'm Pil Hyung Lee from Asan Medical Center. I'm very glad to share my CTO case today. I just want to introduce my case today. This patient is a 48-year-old male patient. He was referred for the treatment of RCA-CTO lesion from another hospital. Actually, he was diagnosed with unstable angina 8 months ago and underwent PCI for circumflex. At that time, the operator tried to do the RCA-CTO, but it was unsuccessful. Today, I'm going to deal with this RCA-CTO. He has a history of hypertension, hyperlipidemia, and he doesn't have any history of MI. So I think we have to discuss about the indication of our CTO PCI. So if you look at the ECG, there is no definite evidence of pathology Q. You can see that he has some degree of cardiomegaly. And the echocardiograph revealed that he has a definite wall motion abnormality at the inferior wall, and his global LVEF was 43%. We underwent the thallium SPECT, and there was a reversible inducible perfusion defect at the RCA territory. So that means that this patient has a ischemia induced by the RCA-CTO, but still we think that the myocardium is viable according to the ECG and the thallium SPECT result. So maybe we can have some large degree of benefit if we successfully recanalize the RCA-CTO. So I think personally this patient has a good indication for CTO PCI. So this is a CT angio of this patient. If you look at the LAO view, now the good part is that the CTO segment is quite straight with less tortuosity or angulation. You can confirm this finding at the RAO view, which is the same finding. The CTO segment is quite straight. So there are some dense calcification spots here. In the LAO view, if I'm lucky to see the calcification in the angio, then I have my wire has to pass through the CTO segment at the greater curvature, toward the greater curvature of the first calcium. And at the RAO view, maybe the wire has to go at the mid portion of the first calcium. We can find out that the angulation from the proximal cap is a little bit about 45 degrees, 45 degrees toward the CTO segment, and there's no calcium at the entry point. That's a good part. Okay, this is the baseline angio of this patient. You can see that I used the 7 French bilateral femoral puncture, and I used the 7 French XB guiding catheter for the left and the 7 French Joaquin guiding catheter for the right at the beginning. I used the Joaquin because the ostium of the RCA was very short, and I wanted to first evaluate whether I could use the Amplatzer guiding catheter after the evaluation of the anatomy. So you can see that the epicardial collateral is intact, and the stump is very blunt, and we have an island, and there are some maybe some microchannels or the space induced by the reverse card at the previous procedure at the proximal portion of the island, and there are some microchannel at the distal portion of the island. That's a good point. The bad point is that the starting point is very short, and I'm not sure that whether I can negotiate the proximal cap. So next, this is the AP cranial view. You can see that there are some microchannel at the distal bifurcation of PDA and PL. So maybe the wire can pass through the distal portion of the RCA, and maybe because of the competition flow, we can't see exactly whether the microchannel is connected between the distal portion and the island, but I think according to the previous procedure, there may be some space between what we think at the portion of the distal RCA CTO. So I think that's a good point. 다음 거. So the tortuosity of the epicardial is not that bad. I think we can negotiate this collateral channel with the contemporary wires and the microcatheter. And the starting point, as I mentioned, the collateral is covered with the stent strut. That is a bad point right now. 다음 거. So first as you saw, this case is a CTO, RCA CTO case, and at the starting point, there was a definite CTO at the proximal. I'm not sure whether it was a tandem CTO or not, but there may have been some microchannel at the distal, but definitely there will be large amount of plaque at the distal RCA as well. So the point is that there are two major RV branch at the island, which I think we have to save if it's possible. And the blunt, the CTO, the entry is blunt for this case. And there are some retrograde channels, including the epicardial and the septal. So for this case, what kind of strategy could we use? I just have some question for Kambis. Will we have some space for the ADR for this case?
Well, first of all, I think it's absolutely important to do a correct puncture at the proximal cap. So therefore, we have to think, do we have an CT co-registration possibility in the lab? If yes, maybe we can even say we make a puncture without IVUS, but it would be very great to put the IVUS probe there and do really controlled puncture of the IVUS. That makes me thinking a little bit about still if I feel really comfortable with 7 French, or if I should rather step up to 8 French from the beginning if I do an IVUS controlled puncture. It depends a little bit on the devices you have, which IVUS you have. Actually, we know the Boston IVUS is good compatible with a Caravel, a low profile microcatheter, or you take a Medtronic guide, which has also a little bit in 7 French, bigger inner lumen than the Cordis guide, which would also work with a Philips and the Caravel, or low profile microcatheter. But so here, probably in case of backup and everything, 8 French would be also reasonable for me. So regarding then the puncture, if you do a very good puncture at the proximal cap, what we have seen actually is that there seems to be not too much calcification. So I think if you really do an IVUS controlled puncture and you make the puncture perfectly, probably step down regime and channel tracking or intraplaque tracking will be successful. For sure, if you fail and may end up, let's say, in a subintimal there, you have to think about the side branches. So one side branch connection is the proximal side branch, who is going from the right marginal branch to distal right marginal branch. It's an ipsilateral channel. I don't personally think that this is really a very important side branch in case of RV, let's say, RV function, but there is also a very nice collateral coming, a huge collateral, big right marginal branch collateral. This should be preserved if possible, for sure. So Therefore, once the wire is in subintimal at the distal cap, we have, let's say, two possibilities. One would be, because there's not so much calcium, would be to use a dual lumen microcatheter to do really a controlled antegrade reentry. So in a parallel wire technique, so from intraplaque towards punctured distal cap. So still, if this doesn't work, ADR, let's say a controlled stingray reentry would be an opportunity. But despite we have to think really there, it's important to do the hematoma control. So therefore, the hematoma can be controlled with a mother and child catheter, which has really to be encroached into the CTO body. And then we have to be sure that we don't lose the big side branch. So this must be an absolute control re-entry at the point there. And we have high chance of possibility for the re-entry there. Because there is not a lot of calcium. So I think the case is very well chosen for educational purposes. It's a very good case regarding IVUS control puncture. It's also a very good case once the case turn into retrograde to evaluate retrograde options, which are probably septal, but also epicardial ones. We may go probably later on to the epicardial analysis and also to understand the different scores we have nowadays for analyzing epicardial passage. So I think it's a very interesting case.
Yeah, I absolutely agree with you regarding the antegrade puncture point. So personally, I really spent lots of time, gathering information where I have to puncture regarding the IVUS or CT or previous angio. And also procedurally, I spent quite a time to correctly puncture the point where I wanted to. Because we all know that if you get a right puncture, you can make a difficult case very easily sometimes. But if you don't,
exactly.
If you don't, you can have an easy case very difficultly. So that was one concern of me in this case. But I want to comment for the puncture effort in this case because the entry of the CTO was quite short from the RCA ostium in this case, and the second obstacle was that there was a stenosis just before the entry. So it means that there are some, the angle of the wire and the entry point will be, not good because of the stenosis at the proximal portion. That was quite an difficult portion in this kind of case. So I think we can proceed and look what I did.
Evaluated the IVUS at the RCA entry to find out where I have to puncture. So can we see the IVUS? This is the conus branch here, 2.0. And you can see the RCA entry is right at the 6 o'clock right there. And this is where we saw there was some disease at the angio. And then coming to the guiding. If we co-register this finding with the angio, you can see that the RCA entry is between the normal portion, angiographically normal portion of the conus branch and a small branch at the more proximal portion. And between those 2 points, I think there's the point that I have to puncture. So as you can see, I try to puncture the CTO entry using a Corsair microcatheter and Conquest Pro 9, but it was difficult because of the proximal stenosis, which has a small lumen, and it precluded me to do the wire controlling. So what I did was I ballooned the proximal segment with a 2.0 balloon, and I tried.
So if you look carefully, I firstly evaluated the CTO with the JR, and subsequently I changed the guiding with the AL1 short chip. So, it is quite difficult using the JR with using the JR to puncture the CTO entry usually, but the reason that I chose that was the angle of the JR will be more favorable for this kind of case. But of course, the backup was so low, so I changed to the AL1. The problem of the AL1 in this kind of case is that the AL1 faces toward the lower portion of the RCA, so my wire has to go upward toward the stenosis and then downward toward the CTO entry. So that was quite a difficult aspect to puncture the white space in this kind of case. So Habara,
I think what is also, may I only comment one thing and ask also Habara, Maoto, because one thing is interesting here. When you look at the IVUS, you see calcium. Right? But you don't see on CT. So this is very important. Also, I think for the people who are not so advanced to understand this, that it's possible, right? To see still some fibrocalcification here on the IVUS, but not on CT. So therefore, I ask Dr. Habara, the wire choice of puncture. Still in Europe, we don't have any steel. We don't have the Gaia 3 next or the Gaia next. So regarding the deflection, because it's going a little bit down, right? So, and we know the behavior of the Conquest 12, who after puncture just go straight. What is the wire of choice for you in Japan for this kind of scenario?
So that depends on the IVUS, but so this case is a little bit hard plaque. So that so we usually need a conference series, but so usually I try to use Gaia next to second or third at first, and if failed, easily step up to the conference. But this case is of course backup is so very weak because very proximal CTO. So that's so if I am an operator in this case, so I use 8 French guiding catheter, and so insert 2 wire to corners branch, and 1 wire is IVUS. And 1 wire is so I use double lumen catheter, Sasuke or Sasuke. So that's so this case is a backup is very important to puncture, but so this case is no stamp CTO, and so proximal side visceral is so large, so that's so backup is very weak. So that's so to make a correct puncture. So IVUS guided puncture is very important. So that's so we need 8 French, and so to make strong backup, so we use a double lumen catheter.
Okay, so you want to do a real-time IVUS evaluation puncture, right? Yeah, I absolutely agree with the 8 French. Yeah. So first I used the Gaia 3rd, and then I changed to the Confianza 9. And I actually failed to puncture the proximal.
Do you have the next Gaia 3 next or the Gaia?
No, we don't have the next series.
The same for us. Okay.
And in proximal segment of the circ, Sion wire to enter the epicardial branch arising from the circ. The microcatheter is a caravel. I did a tip injection here. You can see that the epicardial collateral at the right side is more dominant. The left side, I'm not sure whether it's connected or not. So I tried to wire it on the right side, and after advancement of the microcatheter to distal portion, I did a microinjection. I confirmed that it was connected at the distal, but you can see that angulation at the connected portion between the collateral and the PL is not that favorable. I tried several times again, but it was not that easy. You know, the wire always went to the distal portion of the posterior lateral branch. So I tried to negotiate another branch here at the left portion, but it was not easy, of course, as expected. And using several different wire, including Suo 03, Sion Black, and Sion series, I finally negotiated to the proximal portion of the posterior lateral branch. And after I advanced the wire and the microcatheter toward the distal RCA, right, like this, I used the Gaia second wire to go in through the proximal portion. You can see that the wire is in an incorrect position, so I relocated my wire like this. Now, okay, it goes in, the wire is free of resistance. And then after a small injection, I confirmed that the distal wire is in the lumen.
So I think I have to explain why I choose the epicardial collateral rather than the septal, you know, because
yes,
there
in general, the question is, why did you change strategy here so early?
Oh,
maybe I missed the point.
For the retro, you mean, right?
Yeah. So why didn't you first try to prepare antegrade cap?
Yeah, you know, actually, the wire could not go in the point exactly what I wanted. So
okay.
my strategy was that if I could just go in with the retrograde, I just wanted to keep my wire in the true lumen and go for the retrograde wiring. So
I understand.
Yeah.
So you have the cap ambiguity, so you don't know exactly where to puncture. You couldn't puncture correctly. And one option is to have a retrograde wire to puncture antegrade towards the retrograde wire.
Right.
Okay.
So that was a reason.
Once you decided to go retrograde, so what was your rationale to say epicardial versus septal connection?
Yeah.
So I think I have to explain that. You know, this was a failed previously failed case, and that there was some potential septal branches there, but there were two aspects. One was that the previous operators did lots of septal surfing, and they failed to do that.
Oh, really?
Yeah, right. And the second one is that anatomically, I'm really sorry that I could not prepare the septal anatomy here, but anatomically, there was lots of tortuosity at the distal portion. So according to my experience, I thought that it would just, you know, it would be very unfavorable and I would waste my time regarding the septal wiring. So if you have two options, epicardial and septal, of course you have to use the septal because we can make lots of backup, more backup with septal rather than the epicardial. But I choose the epicardial here because of that two reason, and I was worried about that the stent was already put in the ostium of the epicardial, but until now, I felt no resistance. That was a good portion until now.
So one question which I have here at this point is, and two of you as operators, because now there are data out, right, of the passability of non-septal and septal collateral, so which is the G channel score from Japan, actually, where also Kato Sensei was also one of the co-authors. And another was from Taiwan, from Huang, where Paul Kao was the senior author. So the Huang score, I call it like this. So the Huang score is describing that it's very simple score. It's describing then when you have a really big epicardial, so CC2, and no tortuosity, you already have 3 points, and the chance of passing is very high, up to 95, 90%. And in the G channel score, we have some predictors, which are reverse band, corkscrew, and continuous band, so corkscrew, and also very small collaterals, which give us also a little bit of, let's say, a feeling of when you analyze it, of if you have a passing chance or not. So my question is, in your daily practice nowadays, when you study the angiogram, are you also considering those scores? Or is it more that you say, okay, let's say I have so much experience, I know approximately if I can pass? Or are you also already using artificial intelligence in algorithm? So, which is always my dream, that my computer says to me, I analyzed the last 2,000 cases of you, Dr. Mashayekhi, and the chance of this collateral is very high. So what are you doing nowadays, and where are we going in future?
Well, I think that, we don't, in the real practice, we don't systematically calculate that score. I think it's the same situation using the syntax score for the left main or the triple vessel. So, but we put lots of importance at the individual components of that scoring system, and I think experts or the CTO operators unconsciously, use that scoring system according to their experience. So I really agree with using that score, but I also put value on the personal experience with CTO experts. I think that's not different. It's the same situation. So for this case, the tortuosity was quite high, and the diameter of the septal was small. So that puts the score very low for the G score. So that was the one reason that I choose the epicardial.
And I think one important thing also is, whenever you tackle this kind of epicardials, because I mean, it's not only the experts are doing this nowadays, it should be really important to have the coils right in place. So which coils are you using, or which do you have in your lab, if this epicardial rupture? So what would you use for coiling it?
This, of course, so we use C stopper. So that is 0.041 inch. That is so we can use every microcatheter. But this epicardial channel is a little bit very large vessel. Sometimes we need 0.018 coil.
Yes.
Yeah. So
yeah.
That's important. Yeah.
Yeah. Cook one. Yeah.
Yeah. Sometimes, and then you need also different microcatheters.
Yeah.
And,
Yeah. So that's a
which
big
means Procrate, for example, to have the let's say a tornado from Cook, and the combination with a Procate 2.7, for example, you might be very safe. This is important. I think the message to the audience is that we need compatible coils for our tiny epicardials, which fits with every let's say a microcatheter is with Fine Cross and Caravel and Corsair Pro XS and everything. So to have those kind of coils, and like Axiom or Concertino, it's just a one, or like Habara said in Japan. So, and then sometimes you have to think bigger vessels, 2.5 or even 2.0 vessels, which may higher risk of bleeding. We even need bigger coils for the Procrate microcatheter Cook, as you mentioned.
Yeah, exactly.
Okay.
And so I did not check the septal channel, so that's so I didn't know. So that's possibility of the cross the septal channel. So but check the major septal branch is very important in this situation. It is more safer if the possibility is high.
All right.
Okay.
The problem was that the Crusade, the Caravel microcatheter would not advance.
Well, Dr. Phil, so I have another question. So did you check the chip injection from the retrograde of the near the bifurcation? So you chose the Gaia next Gaia next 2. Gaia second, but also if there is a micro channel or something, so we can you can choose the XTR or some guide wire.
Yeah, I actually chose the XTR first, and then changed to the Gaia second because I felt lots of resistance. So I really apologize that I edited my procedure because of the time limit.
Yeah. But so in this case, so the image quality of the channel is very important. So that so chip injection near the CTO exit site is very important, I think.
Yeah. I actually did the tip injection, and it actually was not different with retrograde injection. The microchannel was not that good. I only saw the starting point.
Okay.
Exact same position situation with the previous procedure. So what I did, I tried to remove some factors of the microcatheter, that precluded the microcatheter advancement. So tried to balloon the stent throat with a 1.0 and 1.25 balloon, but it didn't go in easily. So what I did, I tried to use another microcatheter. It didn't go in, so I did a balloon anchoring technique through the circ, which was stented again. I used a 2.5 balloon. I anchored it. Okay. And then I ballooned it with a 1.25 balloon at the stent throat, and I changed the microcatheter to the corsair long. So the reason why I used the corsair was I wanted to drill the corsair through the distal RCA, which was another CTO or a stenosis portion. Okay, this is the process that I did. Now I used the sealing wire to negotiate, and then changed it to the Gaia wire again using the corsair, but unfortunately the corsair will not go in through here. So this is a problem. We do not have a good microcatheter support at the distal. We have to wire in this position. That's a very, very drawback of this procedure. So next thing I did, of course, I have to do the Antegrade wiring, at least for the preparation, or the wiring, or the reverse card. So
you saw that I changed the microcatheter from the caraver to the corsair. So the caraver could not go in toward the proximal RCA at the distal. It will never go in. So what I did, I had to overcome some situations that I had. First, I widened the strut using a small balloon, and then I changed the microcatheter to the corsair. But I could not overcome the obstacle of using the epicardial channel. That means that the epicardial channel does not give you lots of backup for microcatheter advancement. So this was a really big problem in this case.
Don't you use fine cross?
Yeah, we have fine cross. Would it be better to use a fine cross in this kind of case?
So that this case is you cannot pass in a very tight region. So if such a very calcified region is caravel or corsair is not has a big advantage. So in that situation, fine cross is sometimes resolves such a problem. In Japan, recently, we have a Jizai. So that is a new microcatheter that is developed from the fine cross. Yeah, so that is recently we sometimes use, and
Chisai, the name is Chisai?
Jizai. Yeah,
Jizai.
that is by the thermo company.
Okay.
Yeah, that is sometimes this situation is very useful.
Yeah, thank you.
Soft microcatheter.
Thank you for the comment.
But this is a very difficult scenario when the retrograde microcatheter cannot be advanced even towards the distal cap. This is almost really very, very difficult scenario. I mean, in non-epicardials, actually what I do is, because the newer low profile balloons are so good, I go for retrograde dilatation, right? With the 1-0 Ikatsuki or Ryurai or so. But in the epicardial, well, you know, it's a little bit different because you only have the monorail part. So I would not recommend to do this here. But in the septal, it's still feasible and almost also safe in my experience.
Yeah.
But now you really can only go up with the microcatheter, and you have really limited scenario now.
Yeah.
Because the reverse card is getting more complicated, so you have kissing wire as an option now. And if you are able to do reverse card or something, you have to do a tip-in or rendezvous something, how to get the connection. So in the, let's say in the catheter. So very interesting.
Yeah. Did you really have any experience using a balloon toward the epicardial?
Well, you know, this kind of epicardial, I would be a little bit restrictive. Sometimes if they are not so tortuous and going over
Very
the
straight.
apex and maybe, but I also put once a stent over such a big epicardial, stented retrogradely. But in general, I would not recommend to do that because you can't cover the whole wire with the monorail part. So especially in this very long epicardial, and you have to dilate the whole way up, it might be a little bit an issue. So here I would be more conservative, not going over this with
and
the risk of
point,
rupture is too high.
One choice is also OTW balloon. But so we need a long one.
So realistically, realistically, you know, in Korean situation, I think you all know that we have limited option for selecting lots of microcatheter wire. We only can use two microcatheter for one case or integrate retrograde in Korea. I already used 3, so another microcatheter was not an option for me. I'm sorry.
I understand.
Okay, let's go on.
I again used the Sasuke microcatheter and Conquest Pro 12, and then try to advance the wire where I want it to go in. So the advancement was done like this, but yeah. But actually, I tried to confirm the position of the wire through the IVUS. Can we see the IVUS here? If you look at the IVUS, this is a conus branch. You see that this wire is in the subintima portion. It's definite. So according to this finding, I retrieved my my wire and try to relocate the antegrade wire at a more proximal portion. So this is an IVUS guided wiring puncturing technique.
So the reason why I located my antegrade wire is that I had limited option with the retrograde. So just puncturing it, the wire is you know, always goes to the greater curvature, and the retrograde wire is not at the greater curvature. I do not have a retrograde microcatheter option. So if I just proceed with that first wire, I have limited option. That's why I relocated my antegrade wire.
So after I put my wire at the more proximal portion, I did another IVUS examination. Can we see the IVUS? Okay. So you can see there are superficial calcium there, and you see the wire. So it's definitely in the different position compared with the previous one. So I'm not sure whether it's in the right position, but at least it's in the RCA, and I don't look that it's very unfavorable. So I kept my wire in this position. I'm going to try the integrate wire, at least for the reverse cards, or if I'm lucky, an integrate wiring. So this is my position right now. Okay. I'm going to do a balloon anchoring through the conus with using a 2.0 balloon.
The microcatheter could not pass.
Okay.
and try to advance the microcatheter through the cap. The last backup through the RCA guiding catheter is a major drawback of this procedure. Okay, the 2.0 nominal.
No.
Nominal pressure 6.
6.
Okay. 그거는 저기 좀 잡아주세요. Please I'm going to drill my collateral microcatheter to go in through the cap. Okay, I have some advancement here, right? Okay, save please. Okay, at least I think the tip has go in through the entry. Okay. Okay. All right, inflation. 자, 마이크로카터 좀 잡아주세요. So I'm going to check the position of the wire in multiple views, if it's okay. So I think it's not bad, right? The retrograde wire is, at least in my feeling, it's in the intra-proc position. And at the RAO, at the cranial, and the RAO, it's not bad. So considering the lumen diameter, at least vessel diameter, at least 4 or 5 millimeter according to the CT, so this position is not bad. Okay. The proximal, the antegrade wire is conquest still. I'm not going to change my wire because I do not have much support the proximal portion. At least I need a stiff wire. I'm going to change my wire to a Gaia third, which is more controllable and have a higher, a better tactile sense. So I can assume where my antegrade wire is. Because there is a lumen at the mid portion of RCA, which is an island. I actually want to go in through that portion with antegrade wire, but if I can't, I'm just going to do the reverse cart in this position. Okay. The problem is that I have less microcatheter support at the distal, and even if I do the reverse cart, it will be really hard to advance the retrograde microcatheter to the guiding catheter, even with the balloon anchoring. So you can see that I had some progress, and I checked in multiple views, in RAO, and the wire is quite near in position. So the antegrade wire went to the branch, which is RV branch, according to the baseline angio, and that means that antegrade wire position is.
So I was very lucky in this position, you know. I did antegrade wiring, and I subsequently found out that the antegrade wire was in the branch. That means it's in the island. So in this position, would you do the would you select the reverse cart at this point, or would you deal with the antegrade wire and do the use the antegrade wire to do the distal wiring?
So the antegrade wire is in branch as correctly, so I will balloon dilatation from the proximal site at first, and then check the IVUS.
All right. Check the IVUS and decide.
So
okay.
For me, probably I would probably try to advance with the micro, and then change to an extra support wire, and then use the dual lumen and try to wire into the main branch.
Yeah,
Because
that's a good
so
option.
if
But only with soft wire. Only with soft wire, because what Habara is thinking already with IVUS is, if you pass subintima and in the side branch, and you may have subintima shift, then you might have no chance for rewiring. There is so therefore, for sure, IVUS has the advantage to understand this, but also we have to be a little bit of control of potential hematoma there. But
right.
no.
Okay. So actually, if you don't have confidence with the integrate wire position, that at that point the answer would be the reverse card, because most of the time reverse card is more efficient. But let's see what I did from now.
Quite good, at least in the distance. So what I did the proximal ballooning, the reverse caught 2.5, 2.5, but the wire could not go in, so I checked the IVUS to check the position of the antegrade and retrograde wire. So as you can see, the proximal portion is a subintimal place, but the good news is that you can see that the wire from the antegrade to retrograde is in the same place in some area, right? Okay, could you show us the position of the wire where it is in the same place? Okay, right here. So the antegrade wire, which is in the IVUS, and that's the wire at the 1 o'clock is retrograde wire, so it's in the same subintimal place at the proximal. So that's good news. So what I did in this kind of situation, we can use a bigger balloon to solve the problem. So you see that in angio, the wire where the retro and antegrade crosses together, that's the point where they meet. And then thereafter, at the proximal, the retrograde wire goes into the true lumen, I think. Of course, the antegrade wire at the proximal is in the subintimal place. This is 3-0 balloon, and after that, the retrograde wire goes into the guiding catheter, like this. So I succeeded to put the retrograde wire in the antegrade guiding. And after balloon anchoring, I tried to advance the retrograde microcatheter toward the antegrade guiding, but it does not work. It's stuck there. My feeling is that it will never work. So in that situation, what we can do is we can do a rendezvous technique in the guiding catheter. I advanced the microcatheter at the antegrade position and placed it the angulation of the Amplatzer guiding catheter. In this position, the rendezvous technique is relatively easy. You can see that it goes in through the microcatheter like this, right? Okay. And then if I can just advance the antegrade microcatheter toward the distal portion, then I can do the antegrade wiring through that microcatheter. But unfortunately, the microcatheter would not go in at the calcification area of the mid portion of RCA. So I had no option. I did the delegate wiring with the antegrade Gaia 3 wire. And then...
So you can see that I did the reverse card. And I thought that that reverse card technique and using the balloon anchoring and advancing the retrograde wire, or at least using the rendezvous, will be more efficient. But actually, I had a mistaken decision making at this point, which made my procedure about 30 minutes more. So that was one mistake with my procedure. I think to do the procedure more efficiently, I may have to, selected the using the antegrade wire or evaluation of the IVUS, as Habara said, and then I may have finished the procedure more easily. So But as you can see that if you have limited option of retrograde micro advancement, you can use this kind of rendezvous technique to overcome this situation. That's one education point.
Fortunately, it passed through the distal portion of the RCA very easily. Okay, this is the position of the wire. I checked the retrograde. It's in the intraluminal place. I replaced the antegrade wire to the PDA like this. And then after that, because I ballooned the widened the stent strut with a small balloon, after I ballooned the circumflex previous stent with a 3.5 high pressure balloon, and that removed the left system. Because the IVUS could not pass through the distal bifurcation, I'm going to balloon it with the 2.5.
총 길이는 93mm 나왔고요. 못 봤으니까 100mm라고 생각합니다.
Okay. The total length of the lesion is about 100 millimeter. 자, nominal.
Nominal.
6. Okay. Okay, division. 자, 6.
6.
Okay, division. Okay. 14.
14.
Okay, patient. 14.
14.
Okay, patient. Okay, right here. So let's go. Okay. Yeah, 2.75 at the posterior lateral branch. Okay, the orifice of the PDA is relatively good. Okay. Okay, good. So I think maybe I would choose a 3.0 stent. 38. 38. Okay, according to the IVUS, I would like to put the stent at the exact position at the bifurcation portion. I do not want to cross the PL or the PDA because there is a risk of branch occlusion. At least according to the IVUS, the bifurcation list is clear. So actually, I already did a reverse cut. I do not want to do the contrast injection, but at least in this point, I think I need it. 차라리 이게 낫겠어요. 좋죠? 자, 노미널 천천히.
12.
천천히 8.
6, 8.
Okay. 12.
12.
Okay, deflation. Okay, 원점. I have to check the overlap. It's okay?
반 스트로 좀.
Okay, go. Go, 12.
12. 12입니다.
Okay. 14,
14,
16,
16.
deflation. 자, 살짝만 테스트. CC. 괜찮아요? 네, 갑시다. 노미널. 12.
12.
Okay. 14.
14.
Deflation. 자, 18.
18.
20. Deflation. 20.
20.
Deflation. 1 time. 20.
20.
20인데요.
Deflation.
8기압에 가점 나가니까.
20.
20.
Deflation. 20.
20. Excuse me. Okay, patient.
So do you do a routine follow-up angio in selected patients? And if yes, what kind of patient do you follow up for the angio?
So in Japan, so we can routinely follow up angio will be performed about 9 months after the so index PCI. But insurance system is all covered. So follow up angiography. So that's so we can do that.
All right. The Kambis, do you do
So
it?
in Germany, actually, yeah. So in Germany, actually, we don't do routine follow-up. In multivessel disease, if we have another stenosis, something to treat, then we schedule it 3 to 6 months. That we see, that we see also the result or instant problematic if it's going on the CTO side. What I really follow up is actually when I have excessive calcium and also subintimal tracking where I couldn't go through and I couldn't do perfectly stent optimization due to the risk of subintimal rupture. Those patients I routinely follow up for 3 to 6 months, and so if then I do FFR guided re-angioplasty even with higher pressure or plaque modification. But so this is actually at the moment my scenario. But this patient actually, if I have a perfect result intraluminal tracking, it's okay to follow him up clinically.
Yeah. So I do routine angiography in selected patient with excessive negative remodeling at the distal. For instance, a retinal appearance. So sometimes
also an indication.
Sometimes I follow up and find out another real tight stenosis at the distal. Yeah.
That's correct. That's correct. That this makes also sense. And sometimes, if there are remaining dissections where I believe that I covered the entry, I also let it heal to avoid the long stents, and then those kind of patients also follow up. That's correct.
Yeah. How about using antiplatelet agents? Do you use adapt more than 6 months or more than 12 months in this kind of long stenting procedure? What's your strategy?
But in this case is so not so complex reason. So that's so usually so 6 or 9 months. I will change so single.
Yeah.
Same for me. So 6 months in this kind of cases. With this, so 6 months is sufficient.
The guideline indicates that it's reasonable to use DAPT more than 6 months based on the registry observational studies. So I think it's time, or we need more data regarding the duration of the DAPT or the appropriate antiplatelet strategy. We don't have evidence yet.
I think so. What we learned actually now from the data is that between 6 and 12 months, the reduction of serious adverse events is less than the bleeding risk. So when you go long, you should go longer than 12 months. So probably evaluate after 24 to 36 months with precise TAP score and then decide if you go even longer.
Yeah. This is the final
bifurcation.
Yeah, that's important now.
Perfect. Yeah. Okay. So this is a 3.0 balloon, 3.0 stent, and I think I covered this point with the high pressure balloon with 3.5. Stent is well expanded with round shape, symmetrical. Okay. So far so good. Okay, this is a 3.5 stent. It's well expanded. By the way, stent was Zion's. Okay, so far so good. This is the position where there was a lumen. And this is the position where the calcium was. You can see this calcium at 1 or 2 o'clock. Okay, so far it's good. It's expanded at least 3.5. All right, symmetrical expansion. Okay, this is a 4.0.
Excellent result here.
Yeah.
This is the position where like some indentation of the angio. maybe because of the eccentric plot position. But the lumen
Oh,
is
that's
so
clear.
large.
Yeah,
Yeah.
but
Okay.
perfect. No, this is a really good long term. I think there will be everything okay for the long term as well in this patient.
Recently, we published our data in neurointervention, and the most important IVUS parameter is, as expected, the minimum stent area. And if you have more than 4.9 millimeters square of minimum stent area in all of your stented area, the long-term prognosis is very good. So
4.9, you said, yeah?
Yeah, 4.9.
MSA?
MSA, right. So in this kind of case, I would expect a good prognosis. I can use only 6 months of adapt according to the IVUS finding, maybe. So
Yeah, I think so.
Yeah. Okay, so I think this is the case for today. And Habara or Kambis, do you have any comments or last words for this case?
Yeah, so this case is a very difficult case, I think, that because retrograde was succeeded, but retrograde microcatheter cannot pass. So that's so you change it to the strategy to the rendezvous technique, but the rendezvous technique can not can succeed, but antegrade microcatheter cannot pass another proximal portion. So that's so this case is a very difficult situation to resolve such a situation. But so you can resolve the antegrade wiring. So that is also very nice success case. I think that's a very interesting case.
Yeah, thank you.
Yeah, I think it's very well chosen the case, also from educational perspectives with antegrade, IVUS cap puncture, and all the problems you can have in CTO cases nowadays. And I really congratulate you to this excellent result. For sure, it needs time and persistence to go over this kind of cases, and where you already are in a good scenario, but then you have a move back again, and so it's not easy all the time, but it's very well solved and a perfect result. Congratulations.
Thank you. So I'm very thankful to Dr. Habara and Dr. Kambis for taking your time. I hope you your health, your family, and I hope you to see each other in the near future after the COVID-19. Thank you very much.
Thank you so much.
Thank you.
Thank you.